is Bill Fisher. Dr. Fisher is a professor of surgery at the Baylor College of Medicine. He is the division chief of general surgery. He holds an endowed chair. He's a principal investigator for the Baylor unit for the Consortium for the Study of Chronic Pancreatitis, Diabetes, and Pancreas Cancer. And he'll be giving us an overview of pancreas cancer in 2019. Thanks, Bill.
Well, thanks, Walter. And then it's a privilege to be here and speak to you this morning. And unfortunately, we saved the worst for last. So I'm not talking about the speaker, I hope, the disease. So pancreas cancer is the worst cancer that you can get. I'm going to tell you a little bit about that. I feel a little bit this morning like, you know, this is my area of work in my life, and I feel like sort of drinking out of a fire hose here this morning. It's been a really fast series of lectures with really great information. It's like we're reading from a up-to-date textbook, and we'll keep it going here, I hope. So I'm going to talk to you about the diagnosis, staging, and prognosis and treatment of pancreatic cancer. So the big problem with pancreas cancer is that patients present late. They always present with advanced disease almost. And if you talk to them, they've had about 3 months of abdominal pain before they eventually get diagnosed. Many of them will have unexplained weight loss, 10 to 20 pounds. And then, you know, they present with jaundice. That's usually the key thing. Their spouse says, your eyes look yellow. And they look in the mirror, and you're right, they do. And something's wrong. I got to get in and be seen. That's kind of the typical. New onset diabetes is also a really important tip-off. New onset diabetes in someone over age 50, it can be a tip-off. So here's the symptoms. We have a big database, and we track symptoms in our patients of a lot of cases of pancreas cancer. And when the tumor's in the head of the pancreas, you heard a little bit about the anatomy this morning, it blocks the bile duct and the patient turns yellow. And so that's an important part of how they present. But they usually have unexplained weight loss and vague abdominal pain long before they develop the jaundice. When the tumor's in the tail, they don't get the jaundice, and it's even a longer course towards presentation with vague abdominal pain. Here's how we stage it. This is the current AJCC staging. In the top there, you see, you know, what pancreas surgeons want to see, a tumor that's confined just to the head of the pancreas, not touching any of the big blood vessels that you heard about in the first lecture around the pancreas. That's one that can be removed with surgery. Unfortunately, that's only 9% of the patients. And even more unfortunately, that group, there's only a 34% 5-year survival. So that's worse than any cancer. If you think about it, usually when we cut a cancer out and remove it, the patient is cured. Breast cancer, colon cancer, other types of cancer. We're curing cancer every day in all of our big major medical centers. Pancreas cancer, not so much. Even when we completely remove it, we think we got it all, it comes back in a couple of years. 12%, it's regional. And then in 47%, it's like in the bottom panel there, there's spots in the liver. It's already spread and it's late stage. This is an interesting study. So it's about a decade old now, I think, but they did a really fancy quantitative analysis of the timing of genetic changes, the genetic evolution of the cells leading to cancer. And long story short, they concluded that there was at least about a decade between the initiating mutation, the initiating gene mutation, and the birth of the parental non-metastatic founder cell of that cancer. So this got everybody in the field pretty excited. Like, hey, maybe there's a window of opportunity where we could do better here and diagnose pancreas cancer before it's already spread to the liver. In reality, that process that's going on though is very clinically silent and difficult to identify. So if you think about the progression in a pancreatic duct cell as it starts to pile up into a tumor and then invade through the wall, what does that look like on imaging? And probably early on, there are some subtle signs before we see a tumor. This is a really interesting study where they asked the question, well, what if we did get a CAT scan earlier? Would we see a tumor? And I can tell you, every patient that I've seen in my office, when they come in and they're diagnosed with pancreas cancer, that's a big question in their mind. What if I would have gotten a CAT scan a little bit sooner? Would we have caught this before it was so spread? Well, the answer is probably yeah. So this is a study where they look back into patients that were diagnosed and they happen to have had a scan for maybe some other reason earlier. And lo and behold, yeah, there are little subtle changes like the dilated duct that you see, dilated pancreatic duct, maybe not a tumor, but some subtle changes. Some suspicious findings are present. So Resectability may be improved if we got the CAT scan even as little as 6 months earlier than we currently are. So how do we do that? Many of the members of this group are involved in a big consortium of 10 pancreas centers, and we're following patients with new onset diabetes and trying to figure out if we can get biomarkers and things to create a second sieve. So if you think about it, you got to define the population at risk. So maybe that's patients with new onset diabetes, maybe some other criteria, but that's a lot of people and you can't scan them all. So you got to enrich that population some other way. And hopefully that's through a biomarker, a combination of biomarkers, and then we can find it with early detection with imaging. There are other high-risk populations that should be screened. A big area of interest in this field is pancreas cysts. So there are certain cysts of the pancreas that can turn into pancreas cancer over time, mucinous cystic neoplasms and intraductal papillary mucinous neoplasms. So these patients are a very big interest, and there's a lot of studies going on looking at how we categorize these cysts, which ones are likely to turn into cancer, when they should be removed, when they can be watched, a really hot area of research. Most of the patients don't have a family history, but if you have 3 blood relatives with pancreas cancer, or including 1 first-degree relative, then you're in a high-risk group, or 2 affected first-degree relatives. Those are patients that really have a higher risk, and we would want to screen those. And then there are other various genetic syndromes, P16 mutations, BRCA, which you know about in breast cancer, this PULB2 gene mutation. It's not enough to just have that mutation, though. You have to have the family history as well to really be at a higher risk. We talked a little bit earlier talks about hereditary pancreatitis. Those patients are at very high risk as well, and they need to be screened. So how do we screen them? It's a big problem. We don't really know. What's the best way to image them? Currently, MRI is probably the best because it's the patients don't get radiated, and also with MRCP, we can look at these little subtle changes in the duct and probably pick it up earlier. Endoscopic ultrasound is also a very sensitive way to look, but it's invasive. The patient has to be sedated, they have to have a scope put down. So we usually kind of combine, go back and forth between EUS and MRI. So in the real world, it's important to know, and this is a big problem, this is how the patient typically presents. They've had multiple office visits with their primary care physician for this vague abdominal pain. We can't figure it out. They get referred to a gastroenterologist, and the typical response is, oh, let's do an upper endoscopy and a lower endoscopy. So they get upper GI and they get a colonoscopy. Doesn't show anything but gastroenteritis. And then it goes on and on and on. Eventually the patient comes into the ER with jaundice and pain. And then in the ER, they get an inadequate CAT scan, a thick cut CAT scan, only the abdomen, not the chest, may or may not use contrast. So then that leads to another repeat CT and usually an MRI. Then they get referred and they get an ERCP and a plastic stent. And then eventually they get referred to a pancreas center where somebody does an EUS and a biopsy, and then often another ERCP to change out their plastic stent for a metal stent. So it's a really cumbersome, janky, unorganized process, and it's an area where we can really hopefully make some big improvements. Ideally, the patient would get a pancreas protocol CT of the chest, abdomen, and pelvis. And pancreas protocol means 4 phases of contrast, fine cuts. So you can really see what's going on and define the tumor, its relationship to the vessels, whether or not there are really metastases. They need a large core needle biopsy so that we get a diagnosis, and that's often hard for the pathologist to do. And then a metal stent. We use selective staging laparoscopy. So this is a little incision by the belly button. We put a scope in and we look around, particularly in patients that we think are locally advanced to make sure they're not metastatic, because it's really important in clinical trials to get people into the right category. So accurate preoperative staging before they go onto a clinical trial, very, very important, because if there's subtle metastatic disease, you don't want that patient to go on a trial that's for non-metastatic. What about liquid biopsy? This is a really hot area of research in cancer in general, but particularly in pancreas cancer. So if these patients are presenting with advanced disease, we know that the tumor cells are into the circulation already. So there are actually circulating tumor cells in the bloodstream, circulating around. And associated with that, there are these things called exosomes. So the pancreatic cancer cells pop off a exocytosis, a vesicle that's got pancreas cancer DNA inside of it, and that's circulating in the bloodstream. And then there's also circulating free DNA, just naked DNA circulating in the bloodstream. What can we do with that? What can we learn from that? So we've gotten pretty interested in this, and we've found, the way that you do this is you isolate the blood, and it's like finding a needle in a haystack. So you have to stain the cells certain ways with markers to prove that that's actually that 1 in a million cancer cell in the gamish of all the other cells that are in your blood. So we do that, and we found that in 90% of our patients, we could identify circulating tumor cells. And these are early stage patients. These are resectable patients. And we found circulating free DNA in 32% of them. Interestingly, when we gave them neoadjuvant chemotherapy, there was an average of 2 circulating tumor cells per ml of blood at baseline. After they got neoadjuvant therapy, that dropped 3 months later. So chemotherapy is attacking these cells. It doesn't reduce it to 0 in all of them, though. And same thing with resection. If we did upfront resection, we reduce the number of circulating tumor cells greatly. Again, not back to 0. Other people have looked at this too, and it seems as that the circulating tumor cells will start to come back in number prior to the clinical reoccurrence of disease. These 2 slides show that it's bad to have circulating tumor cells, basically. If you have circulating pancreatic cancer cells, your median survival is much less than if you don't. Same thing for circulating free DNA. Unfortunately, this is probably not going to be a good way to diagnose pancreas cancer earlier, but it probably will help to determine prognosis, to assess response to therapy, and to develop personalized therapies directed toward these circulating tumor cells. So really interesting area of research. When I look at that green cell in the top corner there, I have a lot of questions about that cell. You know, where do you come from? Did you come from the primary tumor and get into the bloodstream, or did you come from a metastasis or a lymph node? How long are you going to be in the circulation? What's the half-life of a circulating tumor cell? We don't really know some of the answers to some of these questions. Is it going to go and stick at the first capillary bed that it comes to, or does it keep circulating? Are all circulating tumor cells created equal? Certainly not. They're definitely not. It's a gamish of different types of cells. And are there regional differences? Are the circulating tumor cells in the portal venous system different than the rest of the bloodstream? So lots of questions, really exciting and interesting area of research that hopefully members of this group will get into. We've been waiting for advances, and I feel like we're starting to just see them. This is a interesting thing in pancreas cancers, that chemo didn't really work very well. There's this new 4-drug regimen called FOLFIRINOX. It's a pretty brutal regimen. Side effects from it are pretty severe. But if the patient can tolerate it, it's been proven to help. So the first study came out, of course, in metastatic disease. They compared gemcitabine alone to this 4-drug combination, and FOLFIRINOX was better. Recently, it's been started to use in the adjuvant setting. There was a trial out of France showing improved survival with FOLFIRINOX given after surgery, and now even given neoadjuvant, so before surgery, in case of borderline resectable. Many more of those patients were downstaged and able to come to resection. So that's a big change, and that's something that really wasn't happening about 10 years ago, downstaging patients and getting into surgery with effective chemotherapy. This thing won't advance anymore. If you could just move to the next, oh, there we go. So there was a debate about whether or not you should do surgery first or chemo first, and I think that discussion is really kind of coming to a close now. Most experts in major pancreas centers believe that everybody with pancreas cancer should get chemo prior to surgery, even in the very early cases that we happen to catch. It's not an issue of letting the horse out of the barn. We know that the horse is already out of the barn. Those circulating tumor cells are already there from day one. And if you do the surgery first, it really prolongs the beginning of systemic therapy, in best case, at least by a couple of months. And so we give chemo first. The data for neoadjuvant is now coming out. There was a trial in the Netherlands looking at this, the PRIO-PANC-1 trial, and then another trial recently presented at ASCO from Japan. And so again, really the tide has turned on this, I think. What about sequence-directed therapy? So most of our patients are getting their tumors sequenced now. And there are commercial companies that will do genetic sequencing of the patient's tumor and can get the tumor, get that data back in pretty much real time so it can be used clinically. This is a study where it was a CLIA certified lab, so they could act on the results, and most of the time got the results back within a month, and they found therapeutically relevant genomic alterations in about half of the patients, and it changed the therapy in about a third of the patients. So it's really kind of becoming standard of care to sequence the tumors. And this is from that paper, and it just to point out that there are different genomic features, and there are targeted treatments that are currently available clinically that can be given to patients to tailor their treatment to their specific tumor. And this is an iterative process when they come back with recurrent disease, rebiopsy, resequencing, and redirecting the therapy. Well, I'm a surgeon, so I need to talk a little bit about this. So the surgery for pancreas cancer is also changing. So this is the Whipple procedure, named after the guy that did it first. We reviewed the anatomy earlier, but to remove a tumor in the head of the pancreas, it's a little complex because you have to remove the head of the pancreas, the duodenum, which is attached, the bile duct that runs through the head of the pancreas, and then of course you have to reconstruct everything. So the remaining pancreas has to be reconnected to the intestine, as well as the bile duct, as well as the stomach. So 3 connections that have to grow back together, heal up, and seal without a leak. So this operation has gotten a lot safer. It used to have a pretty high mortality, but now it's down to 3%, really honestly 1% in most of the major pancreas centers, like it is here at Pittsburgh and in other places. Pittsburgh was really kind of took the lead in the robotic Whipple procedure. And it used to be that it was Pittsburgh and a few other centers that were doing this, but now all the major pancreas centers are doing robotic pancreas surgery. It's really starting to take off. So this is a really interesting area for clinical research and health services research type thing. You know, is it better? Is it safe? Are there oncologic differences in these types of operations? From the surgeon's point of view, it's a whole new skill set. You actually are not at the bedside anymore. You take your gown and gloves off and you go sit down at a console, and you're using not only your hands but your feet too to make the robot work. So it's really pretty interesting. Lots of issues about training our residents and to do this and progressing through our own learning curve. So really interesting area. You can see in the picture there, we're using the robot to sew the little tiny 2mm pancreatic duct back to the intestine. You heard earlier about ERAS pathways, early recovery after surgery pathways. This is some data from our group. It used to be the length of stay. You stayed in the hospital for about 10 days after a Whipple procedure, and we got it down to about 6. Recently, we've really amped up our ERAS pathway. You can see all the elements of it over there on the left-hand side. One of the key things, I think, is the way that we're doing the anesthesia, limiting narcotics, limiting fluid. But we've dropped it down now to a median of 3 days after a Whipple, which is crazy. But the patients actually, similar to other studies, have higher patient satisfaction, even though we're kicking them out of the hospital that fast, and we've proved that it's safe. So interesting areas for research. We're also doing telemedicine. When you send the patient home that early, they really don't want to get in the car and drive back when they're that fresh post-op. So we're doing home visits via telemedicine pretty frequently to check on them and make sure they're okay. And we've also extended that to telemedicine consultation now in the preoperative area, so that people can get to us quicker, and so we can hopefully expedite that process of getting the diagnosis and getting what they need and making it more efficient quicker. I want to finish by talking about a research project with adoptive T-cell immunotherapy. This is something that I've been involved with for over 10 years and taken it from the bench to the bedside. And I think this is a really exciting area. So what the concept is you draw blood from the patient and you isolate a certain type of white blood cell called the T cell. We modify those T cells in the lab so that they can target the cancer. And then we expand the population of T cells and give them back to the patient. So infuse the patient's own blood cells back into them to attack the cancer cells. The key here is antigen specificity. So we originally started out by genetically modifying the T cells by putting 3 things on them: a tumor-specific antigen, a co-stimulatory molecule, and then cytokine support. So it was a chimeric antigen receptor, TGF-beta, and then this genetically engineered IL-4 receptor that had IL-7 on the intracellular side, so that when the tumor secreted IL-4 trying to turn off our T cells, it actually turned our T cells on. So we call them smart T cells. What we found out, this is Interesting, really, Caleb, if you could start that video. So the cancer cells are the green cells, and the T cells are the little smaller cells, the white cells. And the person in the lab brought this over to me one day and said, I got to show you this. You got to see what's going on here. So this is, one of my patient's cancer cells. You can see the T cells latch onto it and pop it. And this was like an aha moment for me. I was like, man, we're really onto something. This is totally cool. We got to keep going. So we kept going, and so here's our T cell with a blue receptor. And what we found, it's hard. This area of research is hard. So there's tumor heterogeneity, right? We're doing a lot of genetic studies and sequencing of many tumors. We found that there's over 17 genes commonly mutated in pancreas cancer, and it's a gemisch of cells. So there are cells with the blue receptor, there's some with the yellow, there's some with the orange. And so our T cells were killing off the blue cells. That was great, but we were leaving behind some cells, and those cells just grew back. So it was clear that we couldn't just have a T cell directed against one antigen. We needed multiple antigens. And so that's kind of where we've gone with it. So now we have this multi antigen approach where we're culturing the cells over and over and getting about 6 different antigens. So it's kind of more of a gemisch of an army of T cells with different capabilities. And we've taken this to a clinical trial now, and it was just presented last week at ASCO. And it's complicated. There's about 3 arms to it, but to make a long story short, we've treated a number of patients, and we've actually seen complete response in a couple of patients. So it's not all of them, but it's really, really exciting. And I think this is going to be a key area of research in the future. So to kind of sum it up, pancreas with pancreas cancer diagnosed way too late. That's the key problem with the disease. It's what we need to fix. Chemotherapy and surgery are getting a lot better. The surgery is getting safer. The chemo is getting more effective. We're giving the chemo up front now in everybody, which I think will make hopefully an impact in overall survival. These hot research topics of liquid biopsies and sequence-directed therapies and may improve targeting, and they're really interesting areas of research for anyone who wants to get into this field. And we really think that clinical trials need to be promoted, multi-center clinical trials. Every patient should be offered a clinical trial with this disease until it catches up to the other cancers. Thanks a lot for your attention.